So people who have attended Huddle before, they know the format. It is very informal. We don't talk about all the papers and everything. We just talk about what we do in our life, backed by science. Certainly, we don't want to talk anything which is not supported by the scientific data. So we always try to discuss around a case so that it's almost like something is happening in real life in front of you. So there is no vague, there is nothing in terms of if this is there, I will do this. If this is there, I will do this. Because here you will have a case in front of you. Most of the time, I put myself as the case so that you can ask independent questions and whatever tests and everything. So Praneeth, I'll get started with you. I have a case for you, and then let us see how we can go. Dr. Vrinda is here in the audience. She's an endocrinologist out of all the cardiologists here. She works at Care Banjara as well. So we'll have an endocrinology opinion about these cases as we evolve. So Praneeth, the case is you have got a 36-year-old male who is a IT professional, and he comes to your OPD because he recently got his annual package done, which is sponsored by his IT company. And in the annual package, he finds out that his cholesterol level is slightly off. Otherwise, rest of it is completely fine. I'll tell you about the patient. Patient is a 36-year-old male. You can consider me as the patient. I work on the IT firm. I do a usual 9-to-5 job. I don't have any medical problem. I'm absolutely healthy. I do my typical routine activity. I'm not an athlete, but I do a typical routine activity. I know I don't have any active symptoms. All the other blood tests, routine blood tests that you would get on a package, those are normal, including ECG, echocardiogram. And my lipid profile says, I'll just put all the numbers. You don't have to remember all the numbers, but I will put all the numbers. The only number you'll have to remember is the triglyceride. That's what we're talking about right now. So my total cholesterol is 206. My HDL is 38. My LDL is 120. And my triglycerides are 310. And it is the triglyceride level which is marked on my cholesterol report that worries me. So somebody told me to come and meet a cardiologist. So here I am with my triglyceride level of 310, and I'm panicking. So you are the doctor. Tell me how you will take it as if you are doing it in your clinic, and then we'll ask other people's opinion about how they handle it.
Yeah, so otherwise it might take young. Cholesterol slightly borderline above the reference normal range, which we consider, but definitely triglycerides being slightly high or probably twice than the upper limit of being normal. So questions to you is, do you take alcohol?
So I take alcohol only once a while, maybe like once a week or so.
Okay, and what is your diet like? Do you consume a lot of fried foods or junk food or something like that?
You know, I'm a typical IT professional. I go out with my friends twice a week. I eat some McDonald's here and there. You have to assume this is not a COVID situation. And I once a while I do eat fried food, but I'm not a junkie for fried food, and I eat rice once a day, and just a routine stuff. I don't do anything active either ways.
Okay, okay. So not physically active, but not athlete. So I got it. So history, probably any family history of any heart diseases or anyone having abnormal cholesterol in the family.
So none of my family has any heart disease, but my father takes cholesterol medication because he's diabetic.
Okay, got it. ठीक है. So what is your weight and what is your height?
So my weight is about 80 kgs. My height is 5'8". That makes my BMI around 27.
ठीक है. Then the other question I wanted to ask, blood pressure. What is your blood pressure like?
Okay, so that you have to check, but it is 130 by 80.
Checking. Sorry?
130 by 80.
30 by 80, slightly better. So my approach to this case of so-called isolated hypertriglyceridemia, I would be trying to see mostly it's because of the diet. So I would firstly reassure you that triglycerides alone per se will not isolatedly increase your risk of having a heart disease. Yes, there are few case reports trying to say that it is, but isolated hypertriglyceridemia per se is not a significant risk factor to have a heart disease. What I can suggest you is to change some modification. Alcohol, occasional, agreed, but if you can cut it down the slightly further from whatever you are taking would be better. Need to be better on your diet, avoiding a lot of deep fried foods and the junk food, so to speak. And if you can improve your physical activity, because physical activity has been proven to be reducing your triglycerides level. So if you can improve, do about at least 10 to 15 to start with, 10 to 15 minutes of some physical exercise and scale it up. It can, and we will relook at your triglyceride levels after 3 months. So right now there is nothing that you need to worry about. So do these changes, and then we will follow up with your liver function, with your lipid profile again after say 3 or 6 months. In your health package, I will also try to pay attention to liver function test, and I assume because you only mentioned about the cholesterol, I assume your liver function tests were also normal, and probably your thyroid function is also normal. So these are the two things which I will be looking in your other reports that you have mentioned, and this is what I would the advice that I give you from my end.
Okay, thank you so much, Praneeth. Let me ask an endo opinion about what they would do. So let's see. Brinda, this patient comes to you because cholesterol is high. How would you approach other than what Dr. Praneeth already mentioned?
So maybe I'll ask for your waist circumference also, and essentially to evaluate you for the risk of metabolic syndrome kind of picture. But as Dr. Praneeth mentioned, I think from endo standpoint, making sure you do check, like I do get some sugar check for you. So either a fasting blood sugar or a hemoglobin A1C, thyroid, as Dr. Praneeth mentioned, kidney function. But most likely, whenever we are talking about, triglyceride level, 200, 300, 400 range, we are looking for like secondary causes of elevated triglyceride levels, which mostly are related to either metabolic syndrome, presence of diabetes, hypothyroidism, alcohol, in alcohol use. List of medications, maybe I would like to run through a list of medications. So antihypertensives, glucocorticoids, of course, if it's a female, then I may actually ask for estrogen use. So those are the main things that I will look for. And then I think I kind of agree that, in this age group, talking about you as a patient, I think I may target dietary modification, weight loss, as the before I embark on pharmacological therapy or anything like that.
So Praneeth, I have a question. So let's say this patient, this was his second blood test. Let's say he got one done 6 months ago. That was also high. This one is also high. He has not done any proper modification. He just got his repeat test done after 6 months. They are still high. Would you put him on therapy on the first meeting?
No. I would still, it only implies that he was not adherent to the advice or the advice that was given to him. I could say that, but my threshold to start therapy for isolated triglyceridemia in the range of around 300 is high. So I would still wait, try to reassure him.
So let me ask audience. I'll just pick up a few names. Dr. Patel, we had you on our audience. So whatever we discussed, other than that, is there something else you would do on the first visit of this patient? I'm sure you had had at least a few hypertriglyceride patients come to your OPD. Dr. Patel. Okay, for some reason we are not able to hear Dr. Patel. I'm not able to unmute him as well. Okay, let us see. So let me fill in at least few things. First of all, we discussed all of it. We didn't discuss smoking. That is one thing that is quite important. Smoking is associated with hypertriglyceridemia, so that is important. Second is, while we discussed about lab test, urine examination is very important because subclinical renal dysfunction can also cause hypertriglyceridemia. So your creatinine may not be elevated, but if you have, like, let's say, a protein losing disease like a nephrotic syndrome or something like that, that can also cause. And medications was brought in. Two medications which are equally important for cardiologists is hydrochlorothiazide and or any thiazide and beta blockers. They are detrimental to your lipids, particularly triglyceride, and that is important. The one thing that I will add is, so it is not that hypertriglyceridemia is not associated with increased cardiac risk. It is. It's just that we so far have not found where reducing the triglycerides pharmacologically, whether that reduces the risk or not. That is something which is up in the air. And that is why this whole discussion about whether we should target triglycerides or in a cardiology OPD, whether we should even be talking about triglyceride or not. Because while the data is conflicting, I think the data wins where it says that it is associated with the risk. So most of the people, they do think that it adds to the risk, but how to reduce that risk, that we don't know. The confusion comes because there are certain congenital disease, I can't remember which one is, but there are certain congenital disease where their triglycerides are very high, like those which cause all those xanthomas and your skin lesions and pancreatitis and all these, where the triglycerides are 2000, 3000. There are some genetic disease, I can't remember, and they don't have cardiovascular risk. So that is how the thought came that, people whose triglycerides are 2000, 3000, even they don't have cardiovascular risk. So how can triglyceride of 400 have? But I think the data is pretty clear out there. The risk is there. We just don't know how to reduce the risk. So anyway, let me complete the clinical picture and then we'll go to the step 2 of the discussion. So Pranith, I'm going to come back to you. So let's say this patient, he went home, he did everything that you asked him. He stopped going to McDonald's, he quit drinking alcohol, he started doing 30 minutes of daily activity along with his routine work. He's not smoking, urine, everything is okay, he's not taking any medications, A1C is fine, TSH is fine, all this stuff is good. And his waist is 32, let's say. So he is like borderline metabolic. After 3 months, he comes back to you with a repeat lipid profile. And I will give you other numbers if you ask me, because it will be difficult to remember. But his triglycerides are 250 now. They were 310 3 months ago. Now they are 250. It is done as a fasting level. And he has done everything that you asked him to do. And he has lost about 2 kgs of it. So what would you do now? And any comments you had for previous discussion as well.
No, so the statement which you said was nice. That was a learning point for me, where risk is there, and the other aspect of it, whether the therapy will reduce the risk of CVD. So I like that statement, and that's a learning point. Regarding this patient coming back to me with the report, so definitely he shows some improvement with whatever whatever he did shows equally in the result. So that is convincing both me and to patient. So I would emphasize him to continue the same thing. Again, because it is slightly lower side and whatever is working, I would just continue the same thing and ask him to come to me and follow up after 6 months or so.
Okay, so even at the second visit, you will not start him on a therapy. His triglycerides are elevated compared to the normal range of 150. You would not put him on any pharmacologic therapy.
No.
Okay. We had few attendees who joined late. I'm just going to give you a brief overview of what we are talking. We do have Prashant here. Prashant is our colleague cardiologist at Care High Tech. Prashant, this question is coming to you. I'm just going to give you an overview. So this is a 36-year-old male who came into Praneeth's OPD because his routine evaluation showed triglyceride of 310. Rest of the numbers are okay. The rest of the blood work, urine work, everything else is okay. He's asymptomatic, doesn't take any medication. This was his second reading of consistently was 6 months on. He is kind of overweight but not obese. Praneeth asked him to do the lifestyle modification, quit alcohol, which was difficult for him, and quit all the fried things and just go vegan basically. Just start living a monk's life, which he complied, probably because he liked Praneeth. So he complied with all of that. He has become a monk for 3 months. He had been doing everything right. He came back again. This is his third test. His triglycerides are 250 now from 310. And I asked Praneeth what you would do next. He said he'll continue the medical man, he'll continue the conservative treatment, ask him to come back after 6 months. What would you do?
Hi everyone.
Yeah, Praneeth,
Hello.
you got, Prashant, you got muted for a second. So please go ahead now.
So first of all, hi everyone. Anoop just introduced me. I think I'll agree with Praneeth. We should definitely try for a lifestyle modification. Unless we are looking at pancreatitis as such, if that is ruled out, then I think we can still give a chance for lifestyle modification. Some people tend to give fish oil. I don't know how much it will help, but definitely lifestyle modification would still be an option, unless, of course, there are any other associated complications.
Thanks, Prashant. Vrinda, what would you do? This guy came back to you, triglyceride is 250. You are an endocrinologist. You are not biased for cardiac issue only. What would you do?
So again, as an endocrinologist, I'm basically looking at two things, his risk for pancreatitis and his risk for cardiovascular events. At 250, as you rightly mentioned, that, we're talking about a spectrum. So as the triglyceride number increases, there is an association. How to quantify is probably what we are learning. But in general, the risk for pancreatitis, we start calculating when the number starts touching 500 or more. For this patient, in terms of cardiovascular disease risk, I'd probably look at the background picture. What other risk factors does he have? So in the absence of diabetes, hypertension, smoking, or any other kind of risk factors, family history, all negative, then I may still stick to the same thing: dietary modification, continued stress on lifestyle modification, because as Dr. Prashant just mentioned, that there is some data to say that you know use of omega-3s has been shown to reduce the triglyceride levels. But again, if we are talking about the data where it is coming from, those were all done in high risk population where it showed some benefit. So I think for this person, I would probably just do nothing. I'm not going to put him on medications as yet. So just continue to stress lifestyle modification.
Okay, the forum is open for anybody to give their comment, because the whole idea is to learn what other people would do. It is not an expert session, and it is not intended to. None of us are experts here. So anybody, please unmute yourself and tell us if you would do anything differently, or if something that we missed that we should discuss. If nobody speaks, then I speak, and then it becomes a problem. Okay, all right. So if nobody has any comments, then I will just add few things. So first of all, Vrinda, I have a question for you. What are the chances of this guy having a genetic hypertriglyceridemia with that kind of numbers?
Um, so usually in like routine practice, we do not test like for genetic mutations. But because the association has been more when you see triglyceride numbers more than like 1,000. So people with familial forms of hypertriglyceridemia usually have triglyceride numbers way above and beyond like 1,000, 2,000, 3,000. So I think, for this patient with no similar family history, I will not offer him genetic testing because, again, it will not change my plan of, treatment for him. So,
But do you think, with that number, what are the chances of him having a genetic predisposition? Because that way, I will check his family members as well. With those numbers of 250 and 300, what are the chances of him having genetic issue?
again, so like I said, very low. So
Very low.
very low because usually like these people may have the same picture as you painted. Young guy, 36, may not have any symptoms, may not have like xanthelasma or those xanthomas. But usually the triglyceride numbers will be very, very high. So usually to the order of like thousands that we see in patients with familial forms. So I will not offer him genetic testing.
Um, Praneeth, I'll come back to you. And I keep coming back to Praneeth, Prashant, and Vrinda because none of the other guys are talking. If you want to add anything, then I'll be more than happy to unmute you and get your opinion as well. So Praneeth, this patient comes to you for the second time. This time he is not happy with your recommendation because somebody told him that no, 250 is very high. He goes to another doctor who puts him on fenofibrate 145 milligrams once a day, and he starts taking it. He takes it for 6 months. After 6 months, he gets his lipid profile, and now his triglyceride level is 180. And for some reason, he comes back to you saying that, Doc, I'm taking fenofibrate for the past 6 months. My triglyceride level is 180. And what should I do now? And he's doing everything else other than what you said. So basic question for you is, would you continue his fenofibrate or would you stop it?
You exactly hit the bullseye. This is what exactly happens in the routine practice. So, firstly, the your earlier statement of me essentially making the person vegan and he trying to become monk, I like it. That is where I kind of feel okay or kind of secure, where you can win over the patient, where most of the patients don't or not able to so-called apply the so-called strict rules and not. And you have a upper hand, so to speak, where you can say that, हाँ तुमने नहीं किया, this was your triglycerides are high. But yes, you do encounter these situations where you rightly pointed out, where the patients are being started on fenofibrate and the drug works and the triglyceride levels come down and they come back to you for kind of second opinion or a suggestion. This is a tricky situation. Which definitely makes me uncomfortable. Uh, I would do personally, not to disrespect the other physician, I would give my honest opinion saying that I probably would not have, or the level does not seem to be significant enough for me to start triglyceride. But now that you have already started, and the drug seems to be working to you, and you are tolerating it well, and you don't have any problem, there's no harm in probably taking it. You can continue. I'll leave the decision to you. But personally speaking, if I would still re-emphasize that I was not convinced to start therapy at the right point of time. So it's up to you whether to continue.
Anyone has any thoughts about hypertriglyceridemia? This is, if you're a practicing cardiologist, you have seen this clinical presentation. at least more than a dozen times in your OPD. If you are not a practicing cardiologist yet, believe me, you will see this every now and then in your OPD. This will happen very commonly. These are the patients who are kind of less satisfied because they are typically young, they are active, and they are concerned about their overall well-being. So this thing will come to you. Prashant, you have something?
Yeah, I just wanted to ask, like, would you guys add niacin for him, like, uh, maybe as a placebo or as a part of the treatment? If it tolerates, should we continue niacin in such individuals?
Prashant, I will ask you because here it's all about, because there is no hyperlipidemia expert here. So
No,
the
no. I
idea is
mean,
not to ask.
I mean,
Yeah.
like, I've not used niacin that frequently, but in whatever little patient population I've used, they were definitely had side effects. Like, many of them didn't tolerate it. So, just wanted an alternate view, like how comfortable or how frequently we'll use niacin in such individuals, if at all, if it is indicated.
So US loves niacin,
Yeah, yeah,
and I have used niacin more than what I am proud to say that.
yeah.
Partly also because I was in training and I was doing what people were telling me to do.
Uh-huh.
But niacin tolerance is an issue,
Yeah, yeah, that's right.
and early on there was this lot of hoops and loops about niacin increasing your HDL and being that gold standard, and being a vitamin, you would say that okay, it doesn't have any side effect because it's a vitamin. So what wrong it's going to do. But a lot of issues. People started prescribing aspirin, because somebody who's
Yeah.
taking aspirin and niacin, it is easy. You tell them to take aspirin and then take niacin after half an hour, and they do fine.
Okay.
But people who are not taking aspirin, sometimes people who have the soft indication for aspirin, sometimes we started prescribing aspirin to combat the effect of niacin, and
Uh-huh.
this whole argument just went down the road. So I will tell you, there is a group of hyperlipidemia expert in US who very strongly believe that the niacin theory is all wrong,
Uh-huh. Yeah,
because
yeah.
it has always been a generic drug. There was no any pharmaceutical backing for it.
True, true.
So there are a certain group of hyperlipidemic expert in US who do believe that niacin helps, but so far in the data set, it is not quite positive. And in India, I have not prescribed it even once.
Yeah,
In
true.
fact, yeah, and in fact, after my training, I have not prescribed even once. I have prescribed during my training multiple times.
Okay.
So that is my thought about niacin. My question from the Indian context is, how about omega-3s? How about fish oil? That is also something I have prescribed a lot in US. Doesn't have that much of side effect other than just bad smell. So do we prescribe omega-3s in India? Do we have like those Lovaza and all those medicines? I have never prescribed one in India. Has anybody prescribed omega-3s? Anyone who has prescribed omega-3s? No? Okay. So, Praneeth, can you say something about omega-3s, because you probably have more idea about this than me?
So I have never prescribed niacin. I have never prescribed fish oil. But the only thing what I have is the so-called parents of people parents whose kids stay in US. They
Hmm.
do send them these cod liver oil capsules or some fish oil capsules, which are in big containers, which contains about 500 pills or so, which I go through. Vaguely remember most of them essentially are, for me, they are all those supplements kind of a thing. I don't pay paid much attention to how much it contains and what it contains. Probably now I'll start paying attention. But that is the only thing which I could see people taking those fish oils. And I say that's okay. Take one capsule at a time. It's not going to harm you. If you are comfortable, just do. The only experience that I have. But personally, did I prescribe to anyone? No.
Okay, Vrinda, you have something. Your hand is up.
Um, so I will tell you, like, I have used fish oil a lot. And so I just wanted to say, like, because Dr. Praneeth mentioned, like, patients taking it from over the counter from the US. Actually, omega-3s work beautifully. Like, if you take it in the right dose, the triglyceride reduction is very good. But of course, the whole idea is when to use it. So I would restrict the use of omega-3s. Like, if you have like this mild to moderate elevation in triglyceride level, which again is self-defined, somewhere less than 500 or so, but they have to be taken in the right dose. So what gets marketed as over the counter in the US has like very tiny doses of the effective medicine. So the correct dose is usually 4 grams per day, which, if we read the label of the supplement, it's actually minuscule amount. Sometimes it is just to the order of like 100 to 200 milligrams in like each capsule. So most of the time that works only as placebo.
Okay, so let me cut the cord with cut the clutter rather with the omega-3s first, and then if anybody has any comments in between, they can unmute yourself. Okay, so omega-3, I can tell you US experience. What Brinda said, India I have not used. I don't know which brand it comes. All the over-the-counter supplement at the max has got 400, 500 milligrams of omega-3s. They don't have more than that. All of you who prescribe metformin, one of the biggest complaint your patients tell you is the size of metformin capsule if you prescribe, or tablet when you prescribe 1000 milligrams. And here you are talking about taking 4000 milligrams of omega-3 daily. Now that's a lot of milligrams in there. So most of the fish cod oil or cod, they are given twice a day, and they don't have the necessary amount. So there was a brand name called Lovaza back in the day, and Lovaza guys somehow figured out how to put 2 gram omega-3s fatty acid, omega-3s in the very small capsule. So that capsule size was about the same as 1 gram omega-3s that you were getting over the counter. And for a long period of time, Lovaza was being used twice a day. So 1 capsule twice a day to make it 4 grams. There were a lot of data about these newer preparations, which were essentially just purified form of omega-3s. And the idea here was you more purify, condense it, make it in a capsule which people can take. Like, you don't want a capsule as big as a tea probe. Now that will be a problem. So most of you probably heard that recently there was this reduce it trial which came. Deepak Bhatt, who is a very celebrated cardiologist over there in terms of trials, he was the principal investigator of that. And they tried a different kind of omega-3 called, I can't remember the name, Icosa, pentyl, something, blah, blah, blah. The brand name comes as a Vescapa. And that was, again, it's the same thing. The idea behind is you take high doses of omega-3s in high risk cardiovascular patient, and there you show risk reduction. And all of them are done on the top of statins. So let's make it very clear. All these drugs are done on the top of statin. So even in this patient, let us say the guy 36-year-old with a triglyceride of 250, if you have to put him on omega-3, you can put him on omega-3. But if you go by the data, whatever data we have is on the top of statin. It is not standalone. And the reduce it trial was criticized because they showed 25% improvement in cardiovascular outcome, which was phenomenally good. But in the control arm, they were giving the control guys some mineral oil, which nobody knows what the component of that mineral oil was. And there was this huge criticism that the Vescapa arm did not have low event rate. In fact, the mineral oil had a higher event rate because you were giving some God knows what fat molecule. And that's how the difference was quite impressive. Again, nobody knows the truth behind, but all these drug makers, they come up with their proprietary preparation, and then they show. But the bottom line is you give omega-3s in high-risk patients who have got hypertriglyceridemia on the top of statin, and you tell yourself that you may be reducing cardiovascular risk a little bit. That I think can be scientifically justified. Okay, that was the rant about omega-3s. Any other questions anybody has? Yes, Praneeth.
So, say for the sake of discussion, now if say this patient really has the risk factors of coronary artery disease and his triglyceride levels are say 500, and I had to start a therapy where that so-called lifestyle modification is not happening, and the weight reduction is not happening. His timings are awkward, where he goes 10 o'clock and comes at 3 o'clock, 3 a.m. Physical activity is not there, sleep is disturbed, and practically speaking, he is not able to have a healthy lifestyle, so to speak. And he wants to take the therapy because of his risk factors of family history and cholesterol being high and not able to comply. Then how do you start and what therapy should we begin with? Fibrates, statin, both. How do we approach?
Okay, so I will answer this question. This was my main pet peeve that brought me to this Huddle topic, because this was what I thought I'll discuss. Okay, so there is going to be some gyan here. I know we talk about practical approaches, but let us, for the next 5 minutes, talk a little bit gyan about what this thing is. So when you check triglyceride body, see, triglyceride is not floating around in the blood, just like free fatty acid is not floating around in the blood, right? Your all these molecules, like total cholesterol is not floating around in the blood. It is always mixed with some sort of particle, like your LDL particle, your HDL particle, or whatnot. So all these triglycerides or cholesterol, they are all roaming around in the blood in some particle form. So the reason why LDL is dangerous is because LDL has got a lot of cholesterol, and it's a small molecule which macrophages can eat, form foam cells, and get stick to the wall and cause atherosclerosis. That's the whole idea behind it. That LDL is a small molecule. On the other hand, triglyceride, they typically roam around the most commonly in this form called chylomicrons. Chylomicron is what comes from your intestine. And again, I'm not talking in terms of some hyperlipidemia expert. I'm just giving you a little bit of overview because that is how I understand this entity. So triglyceride is roaming around in some form of chylomicron. Chylomicron are very big molecule. Your macrophages cannot eat those. And if macrophages cannot eat those, they cannot get stuck to the wall. They cannot cause atherosclerosis. And that is the reason why this whole thought came that people whose triglyceride level are 2000, 3000, they don't develop atherosclerotic disease because their triglyceride, they cannot enter the blood vessel. Macrophages cannot eat those chylomicrons. They are too big. But as the body processes those, how do they process? That you can look into the biochemistry book. But the way they process, these chylomicrons, they start becoming smaller and smaller. So they become like a remnant, they become some intermediary density molecule, then they eventually become LDL, then they eventually become HDL. So as these molecules start becoming smaller and smaller, they become smaller and smaller by taking more triglyceride out of that particle. And that triglyceride is replaced by some cholesterol and some other molecules, some your protein, ligand, binding, and all these things. So as you go towards smaller molecules, or remnants as they are called, now they can be eaten up by macrophages. So high triglyceride, the reason why its correlation with cardiovascular disease is not very clear, because majority of triglycerides are in chylomicron, which are not dangerous. And whatever triglycerides are there in your LDL, not LDL, sorry, your intermediary DL density lipid, or your early LDL or VLDL, very low density lipids, or your remnants, their triglycerides are there and they are dangerous. And your lipid profile cannot differentiate that out of those 250, 300 of triglyceride, how much of them they are getting it from so-called big particles and how much of them they are getting from small particles. Because these small particles, they are dangerous. So that is where I believe in ATP4, they came up with this huge discussion about non-HDL cholesterol, where they said that, okay, you look at your LDL, you look at all of this, but what about triglyceride? Because triglycerides are also atherogenic in certain situations. So how do you manage that? So what they said is you look at LDL, but then you also look at non-HDL cholesterol. And the way you do that by is you take your total cholesterol and you minus you take HDL out of it. So that becomes your non-HDL cholesterol. And the idea here is when you take the non-HDL cholesterol into account, then you take all the other small particles which are circulating in the blood, which your lipid profile is not detecting. So let's say, for example, let's say if you have a total cholesterol of 200, you have a HDL of 40, LDL of 110, and your triglyceride is, let's say, 300. So your LDL is 110, that is all right. But your non-HDL is 200 minus 40, that makes it 160. That means about 50. So 110 is your LDL, 160 is your non-HDL. So about 50 particles are those particles which are carrying triglycerides, and they are dangerous to your blood vessels. They are not taking into account your chylomicron because that you are not counting here. And that is why if you take patients with triglyceride level of 1000, even there, your non-HDL cholesterol is not going to be that high. The reason why you're looking at non-HDL, again, I'm repeating myself, is to look at which all are those particles which are carrying triglyceride, which are dangerous for the blood vessels, not the chylomicron. And then what they said is when you look at the target level for individual risks, so you all know that LDL target levels are different for different risk profile, you just add 30 to that to make it a non-HDL target. So let's say if you have a healthy person otherwise whose LDL target is 130, then your non-HDL target becomes 160. Or if the target is 160, then your non-HDL target becomes 190. And then you look at your risk profile and see where this patient comes to. Now remember, all of these things are done whenever we are talking about triglyceride below 500, where we are not talking about pancreatitis, we're talking about cardiac risk. There, all the studies which show that triglyceride reduction helps, they say triglyceride reduction helps on the top of statin. So even if you are treating somebody's hypertriglyceridemia based upon their risk profile and their numbers, the first drug to give always is statin. And that is where I think the conflict happens when patients come in with their hypertriglyceridemia and they are taking a single drug of fenofibrate. Fenofibrate, you are allowed to add, but you are allowed to add on the top of statin. Omega-3, you are allowed to add, but on the top of statin. So essentially, Praneeth, I'm coming to your question now. If you have a patient with hypertriglyceridemia, where you have done everything else, lifestyle modification, whatnot, and blah, 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 you have done all of this. Now you're talking about pharmacologic treatment. You first thing you ask yourself is the LDL within the limits of this patient based upon the risk profile, 100, 130, 160, whatnot. If your LDL is within that limit, you're fine. If your LDL is not within the limit, you have an indication for statin. Then you look at second, if LDL is within the limit, then you look at what is the non-HDL. Now you are looking at those other particles which is carrying triglyceride. And if your non-HDL is within the limits, again you are done. But if your non-HDL is high, then you have to put them on statin. You are treating hypertriglyceridemia with statin. And the reason why is because you're not worried about the triglyceride. You are worried about those particles which are carrying those triglyceride, which are your VLDLs, IDLs, remnants, and all those kind of things. So that is what statin is trying to treat. So in a patient whose LDL is also within acceptable limit, your non-HDL is also within the acceptable limit, and your triglyceride is elevated. Now you ask yourself, is reducing this triglyceride worth it? And this is where the data is fudgy. This is where the companies who make Vescapa and all these, they will tell you that it is worth it, which I think is up in the air. And I personally, I don't start fenofibrate or Vescapa is not available here, but anything, if their LDL and non-HDL are within the acceptable limit and the guy is not a high risk for coronary artery disease, then there I leave them alone. Regardless of what their triglyceride level is, till the time it is below 300-400, because once it goes beyond that, then now you are entering the territory of pancreatitis, and that needs to be taken care of. The reason why I don't like fenofibrate is because, remember, it has got liver toxicity. So you can't just put a patient on fenofibrate and leave it, and that to a 36-year-old. How many years the guy is going to continue on that? Omega-3 is different. Omega-3 does not have that risk profile. So if they want to pop in omega-3 capsules here and there, that is okay. It's a useless, harmless drug. But fenofibrate is a problem. And if I do have to start, I will start statin first and then a fenofibrate, provided the guy's numbers are outside of the range or the guy's clinical profile suggests that he's at high risk. And then, you can do, because you're all cardiologists, you can do some other kind of risk profiling, right? Just like usually you do. You can do a carotid intimal thickening, you can do a calcium score, you can do a Lp(a), you can do the CRP levels, you can do peripheral vascular assessment, you can do all of that to see if this guy has any other cardiovascular risk, which if present, then you can justify putting them on a toxic drug. There is some data to say that low HDL in itself will qualify for triglyceride lowering therapy, which is non-statin. I don't buy that. I don't follow that idea, but I'm just telling you for the completion's sake, some people would justify giving fenofibrate as a standalone therapy in patients who have low HDL. First of all, I wouldn't do that, even if I first, and then I will do fenofibrate. But remember, in a 36-year-old, how long we are going to continue? Every 6 months, he's going to come and ask you, doctor, should I continue or should I stop? So that, I think, is a very critical element that we all have to understand. I will answer one more question before I hand it over to Praneeth. Somebody asked, what is the role of selaglitazar? So I will tell you, there are, I don't remember the numbers, there are multiple trials and multiple drugs currently under trial to look for cardiovascular benefit of reducing hypertriglyceridemia. And one of the class of medication is this PPAR alpha receptor antagonist. And selaglitazar is one of them. It was not approved in US. I have not prescribed it ever. I don't have personal experience. But as a class drug, I can tell you that PPAR alpha receptor antagonists are not yet in the prime time. So if you prescribe it, that's okay. I don't think we have got good data to back it up. But again, whatever you do, do it on a statin background. If you do it without statin, I don't know how much benefit you are getting. That is all I had. That was for the Gyan aspect, and I'll come back to what individual practice is. So Praneeth, back to you.
Yeah. So you said about some specs, I forgot now right away. What was that? You used some brand name?
Vescapa.
Vescapa. What is that?
It is some fancy omega-3, Praneeth. Some company made it. It's Icosa pentenyl something. You know that reduce it trial.
Okay.
That
So
was
just
shared in our WhatsApp group. Yeah.
Okay.
It was
So
shared
the
in our
other
WhatsApp.
question is now the commonly prescribed commonly seen prescription is that low dose statin with fibrate combination, like the so-called Tonac TG or a Rosavel F kind of a thing, where you have 10 milligrams of atorvastatin and 145 or 160 milligram of fenofibrate. Now the question is now before now as you said, we start with the statin. How high would you go on statin before you start fibrate?
My practice, Praneeth, and then I will open it for other people to recommend. So I don't use a low potency statin unless a patient cannot tolerate a medium or high intensity statin. For me, that does not exist. For me, a 10 milligram of atorvastatin does not exist. I don't start it. So what I have to do is I have to commit myself. Does this patient have enough risk that I have to do a risk reduction for his atherosclerotic heart disease? And if I think this person has enough risk, then I put that person on an intermediate or a high dose statin, potency statin, which to me is atorvastatin 20 or more, or rosuvastatin 10 or more. Those are the only two drugs that I have. So I will put this guy on a medium or intermediate dose statin. And after that, if his cholesterol or his non-HDL is still high, then I will put him on fenofibrate. I will not start a combo therapy directly. That is what I would do. I don't start atorvastatin 10 unless the guy cannot tolerate 40 or 80. Then I slowly go to 20 and then go to 10. That is what I do typically. So I think there is enough of Gyan. Please, anybody who is in the meeting put their comment. Dr. Praveen is here with us. Dr. Praveen is assistant professor at Osmania. I will just brief you, Praveen, what our discussion is. This is a 36-year-old IT professional who is otherwise healthy, whose triglyceride is elevated, about 300. We did all the lifestyle modification, and he's otherwise completely normal, and his triglycerides came down to 250. And he's asking you what to do next. Somebody prescribed him fenofibrate. So now you are looking at it with fenofibrate, his triglyceride came down to 180. So he's asking you what to do, and this is what we are discussing about what should be the best course of action after this. What is your thoughts on the case and everything else that we discussed?
Sir, for this patient, statin has been started, sir.
Statin, he does not have any measurable risk factor for coronary artery disease. The only thing he has is increased triglyceride. And somebody outside, they started him on single dose fenofibrate 145 milligrams, which is tolerating fine for 6 months. His triglyceride went down from 250 to 180.
Okay, considering only the elevated triglycerides, I would have also started on fenofibrate only, sir.
Other comment you had about the discussion that we were having?
Yes, sir. Yes, sir. But after the discussion, I would change the mind and start the statin.
Okay, so again, I want to emphasize that, see, this particular patient, he is not a high risk for atherosclerotic heart disease. So if I had to ask you what would be LDL target for him, so LDL target for him will be 160 because he's otherwise completely healthy. And a LDL target of 160 means his non-HDL target will be 190. His total triglyceride is, his total cholesterol is 200. So, you know, he does not fit into the criteria for anything.
Okay.
Right, for anything, it does not fit the criteria. But having said that, the point of discussion is that every single person like this who comes to your OPD, you do have to look into whether these guys fit into any of these criteria or not. So the argument is not whether to start medicine or not. The argument is whether these guys fit into any risk modifying criteria. Simply reducing triglyceride is not going to give you benefit of atherosclerotic heart disease. You have to look into from the risk profile. Is his non-HDL high? Is his HDL low? Is he a smoker? Does he have family history? And all those other aspects. Or if nothing is there, but you still want to put a calcium score on him. At 36, his calcium score is 50. That's good enough. That is good enough for you to start him on medication, right? Till the time you know that you are going to modify something. Just reducing triglyceride is not a good idea till the time it is not more than 500. That is my practice. That is what I typically do. Okay. Anybody else has any other thoughts, comments, questions, discussion?
Anoop, I still have 2 questions.
Yes, please.
So this that non-HDL thing, that 30 thing is a bit of confusing to me. Just to for the sake of my purpose and probably for everyone, tell me, how do you read a lipid profile once a patient comes to you with a lipid profile report? What is the first number that you look to, or kind of that algorithmic approach, so to speak? How do you look at it?
So I look at, and this is what I think everybody looks at the same way. I look at 4 numbers. So I look at total cholesterol, and then I look at HDL, then I look at LDL, then I look at triglyceride. So these are the 4 numbers I look at: total cholesterol, HDL, LDL, and triglyceride. And here, let's say if triglyceride is more than 500 or 400, then you know the guy is at high risk. If the total cholesterol is more than 200, then you know the guy is at high risk. If the total LDL is more than a certain cutoff based upon the risk profile, which I'm sure all of you know, 70, 100, 130, 160 based upon individual risk profile. If the LDL is higher than that risk profile, then slam dunk, you have to do something about it. And doesn't mean medication, behavioral modification, all those, and then later on medication. And then if the HDL is less than 40, then that's another thing. What I don't look at is LDL HDL ratio. That is too overblown. That I don't look at. And then what I look as is non-HDL. And the way I look at non-HDL is total cholesterol minus your HDL. So in this case, let's say if the total cholesterol is 200 and your HDL is 40, then your non-HDL becomes 160. So this patient has a non-HDL of 160, which by the way was a reported number in every lipid profile I got in United States. US, every lipid profile they used to mention non-HDL, which literally was a subtraction of HDL from total cholesterol. So in this case, your non-HDL is let's say 160, and this guy's LDL is 110. So if let us say his target LDL was 130, let's say. So for 110, he passes that 130 mark because his target LDL was 130. His target non-HDL will be 30 plus 130, which is 160. And this guy has a non-HDL of 160. So that also kind of matches. Again, the whole idea of non-HDL is to look for molecules other than LDL, which are atherogenic. And if I have to go somewhere more molecular, then there is a ligand called ApoB. I believe ApoB some 60, 100, something like that. I don't remember. So ApoB. The reason why ApoB you need to know, the reason why I know ApoB is because lot of hyperlipidemia research looks at ApoB as one of the end result marker. It comes as one of the marker in their lipid profile. So all the research lipid profile, they do mention ApoB. And ApoB essentially means your non-HDL, because ApoB is not present on HDL. It is only present on LDL, VLDL, IDL, remnants, and all those things. So if you measure ApoB, you get a complete risk spectrum of that patient, which is essentially non-HDL. So what is for us non-HDL? That is ApoB for the researchers. So I don't know if that answered your question, Praneeth, or if I made it more confusing.
Yeah, slightly better. Yeah, so what I could have the problem is most of the times the HDL is low. So that is of course probably a different scenario which we should deal with it. In fact, even my HDL is low, less than 40. So we will discuss about my case per se. I will get my lipid profile and we'll discuss in one of the huddles. The other issue is about the fasting state versus non-fasting state. Most of the patients who come to visit, they do come from distant places. Before they sit in your OPD, they already had their breakfast, and then they come all the way. And sometimes you have to order a non-fasting lipid profile. Then how do you look at the numbers?
So let me answer both the questions. So non-fasting lipid profile, it's easy. There is no scientific confusion about it. You get lipid profile done, and any time when the patient walks into your room, it doesn't have to be fasting. There is absolutely no need. The reason why fasting lipid profile came into US is because in US LDL is a calculated value. In India, LDL is a measured value. So when you do a calculated LDL value, then you calculate LDL based upon triglyceride level. And as you all know, that non-fasting lipid profile will have a higher triglyceride level. When it has a higher triglyceride level, the LDL is falsely elevated. So that is why in US, the whole concept of fasting lipid profile came. But here, because we do LDL as a measured LDL, we don't have to do fasting. So here, the only thing in fasting that interferes is your triglyceride. So if let us say you do a fasting lipid profile and everything is okay, your triglyceride is elevated, that's fine. You ask the guy to get a fasting lipid profile done later on, 3 months, 6 months, whatsoever. Most of the questions are answered by non-fasting lipid profile. So that I'm not worried about. Don't go by US, because in US it's a calculated entity. So in US, if the patient is non-fasting, then we used to write special request, lipid profile, non-fasting sample, please measure LDL, and then they would give you the measured LDL. That is one. Second is low HDL. Low HDL, we can have a discussion, but I'll give you very brief. Low HDL is determined by two things. One is your DNA, one is your exercise. You can't change your DNA, but you can change your exercise. The only thing the only intervention which has been proven to raise HDL and improve outcome is exercise. Nothing else. Nothing else has shown to raise HDL and improve outcome both. So if you have low HDL patient, tell him to exercise and tell him to feel bad about their parents that they were born there. So DNA and exercise, those are the two things for HDL, and then we can talk in detail later on. So that was my answer for those two things.
I think one of the chat questions was also mentioning the same, so probably you answered that. And one final question from my end, I'm eating a lot of time, sorry, is about again the question about fasting, so to speak, because in Hyderabad we have erratic food habits, so to speak. The midnight biryani is popular. So when we say about fasting, what is the time? I believe it is 8 hours. I think you or Vrinda can clarify. Is it 8 hours or more than that?
Now it is 12 hours. Let's make it very clear. If you are doing a fasting sample, minimum 12 hours, ideally 14 hours. There is no confusion about it. So the way I tell people is that you do a early dinner. So which means you do a 7 or 8 p.m. dinner, and then next day after 8 o'clock, you get your blood sample done. So that makes it minimum 12 hours, but ideally 14 hours. Lipid profile has a very strict fasting guidelines. So that is I don't think there is any debate about it. That is also pretty clear. There is one chat question. I will answer that, and then I will ask Vrinda to add if there is anything, because it's an endocrine question, and then we'll close after that unless somebody has any burning thoughts. So the question is, what to do in a patient with a triglyceride of 1650 and a TSH of 50, even after correction of TSH? The triglyceride is now 750. What to be given? So the question here is, patient has hypothyroidism and a very high level of triglyceride. What to do? So the first thing is you take care of hypothyroidism. After that, even then triglyceride does not come down. So this is again some gyan which I did not want to tell at that time. So this, in the hypertriglyceridemia or hyperlipidemia business, there is this concept of second hit hypothesis, which means you have one background problem, and on the top of it you have a second background problem, and then that second hit could be another gene mutation, or it could be a secondary cause. So many of the times, these patients who have a baseline genetic abnormality, their enzymes are not working, or they have some mutation in their whatnot, and they have a higher riding triglyceride or any other lipid profile number. And then on the top of it, they have a second hit, either in the form of second genetic disorder or in the form of metabolic disorder like hypothyroidism or diabetes or exercise or obesity and all those things. So most of the time there you take care of the second hit first if you can, like in this case you took care of hypothyroidism. And once that is there, now you look at what is the background result. And if the background result is a triglyceride of 750, so now that comes into the realm of pancreatitis. So there you have to treat both. You have to treat for coronary disease as well as pancreatitis. So you look at the atherosclerotic risk like we discussed already. If the guy fits into the atherosclerotic risk, then you start statin and a triglyceride reducing drug both at the same time. If he does not fit into the atherosclerotic risk, then you would simply start a triglyceride lowering therapy, which could be in the form of either fenofibrate or in the form of omega-3s, like the established omega-3s, not the liver cord oil, or your Vescapa or all those fancy drugs, or your PPAR alpha antagonist, which are now evolving therapies. So at that time, you have to touch it because you can't leave a triglyceride level of 750 alone. So that was my answer to the question. If that question was not answered properly, whosoever asked, please tell me if something else got unanswered. Vrinda, if anything's there to add, please
Sir,
add. Yes,
I
Praveen.
asked the question, sir. Actually, this patient
Okay.
was seen 6 months ago.
Hmm.
So now what you call after the TSH was repeated recently and it is adequately controlled, but the triglycerides is 750. I started him on rosuvastatin 40 mg because he
Hmm.
is 50 years and he is also having hypertension. Now
Right.
my only problem is as he nowadays patients are reading on the nets. He
Yeah.
said that he wants to use fenofibrate also.
Yeah.
So at a dosage of 40 mg of rosuvastatin and also using the other antihypertensives, whether to use fenofibrate or not, I was worried.
Yeah. So, that's a problem. So what I will tell you what I will do. Again, there is no science behind it. I'll tell you what I will do. So very high dose of statin, 40 milligrams of rosuvastatin, that's a lot of drug. And then on the top of it, you add fenofibrate. That's a problem. Now remember, all the statins and all these, they're not very good at reducing triglyceride. They will reduce it by 10-15%. We use it because we're not using to reduce triglyceride. We are using it to reduce the cardiovascular risk. So in these patients, my one of the main target is to reduce triglyceride. So I will probably use like a 10 milligrams of rosuvastatin, and on the top of it, I will use a full dose fenofibrate. That is what I would do, so
Sir,
that I will
actually,
save his liver.
for this patient, why the rosuvastatin 40 mg was used is he's also having raised LDL and he had a stent.
Oh, oh,
So
oh, oh.
that was the reason, sir. I was
Right,
worried.
right.
So now that is the issue. How to actually
Somehow
just
that's a
we
problem.
got a random lipid profile and we
Mhm.
have found it to be 1650. We thought it
Oh,
is a
oh,
false value, but when repeated, he was also found to be having hypothyroidism.
wow, wow.
So that was
So
the issue, sir.
this kind of patient, I would certainly put him on fancy omega-3s if we can get. And I still wouldn't do 40 plus fenofibrate. I would probably do 20 plus fenofibrate. I probably won't do
Okay.
40. Again, a bit skeptical about liver dysfunction. That's about it. But
Yes, sir.
omega-3s can be given. Bile acid sequestrant can be given. By the way, that's a good drug, no side effect, and that can also be given when your triglyceride levels are that high. See, I don't treat that level of triglyceride. Typically, we used to have the lipidologist who would treat that. And in India, I have not found a patient come to me with a triglyceride of more than 500. But bile acid sequestrant are also, and there are certain diet modifications. These patients, you can actually feed them fat. You feed them with high fat diet, which are polyunsaturated, and they actually control triglycerides better. It's a counterintuitive mechanism. I don't know the mechanics behind it, but these patients, they should be given this so-called MCT. MCT is mono something, I can't remember, but they are multi-chain carbo fat, which decrease your triglyceride level. That is also therapeutic, by the way. So you change all their oils to olive oils and all those things, and they help. But that's a totally different expertise. I don't think I have that level of expertise to tell. But this is kind of a ballpark of what.
Sir, actually, for this patient, I did not start bile acid sequestrant, but bile acids, I have a question. Bile acid sequestrant can be used in a patient who is having cholelithiasis?
Bile acid sequestrant can be used in a patient who is having cholelithiasis. Why not? Why not? Is there a problem with that? I don't think so.
Okay.
I don't think. In fact, if anything, that might help. No.
Okay.
Yeah, I think you can use it, unless somebody in the group, somebody in the audience can shed some light into it. And while other people are thinking, Vrinda, what would you do to that thyroid patient? TSH 50, triglyceride 100 and 1016. You treated the hypothyroid, but triglyceride is still 750. What would you do? Endo perspective.
So again, understanding the patient's risk profile. First of all, if somebody has triglycerides of 1600, it's not thyroid alone. So, as you mentioned, you are talking about some baseline genetic issue. So even when you've corrected thyroid, of course, you want to make sure that the thyroid is corrected. And in general, in like routinely, we don't see very high numbers just with thyroid disorders. So anyways, once you've corrected the thyroid, you do understand that this person has residual risk, both in terms of cardiovascular disease as well as risk for pancreatitis. So he does need some sort of maintenance therapy, which in terms of reduction of triglyceride levels. So based on availability, I think, of course, the options are use of fibrates plus minus omega-3s. Usually, as Dr. Anoop mentioned, the concern is for, different toxicities, with, you put combining two anti-hyperlipidemic drugs. So I would probably lower the dose of statin and add on a fibrate. But simply to put it as, a triglyceride level of 750 puts him at the risk for both pancreatitis as well as cardiovascular disease risk. and he needs maintenance therapy because you know that these levels of triglycerides are very high, and in spite of correcting the thyroid issue, this patient still has elevated levels. So he does need long-term maintenance therapy of some sort, be it omega-3s or fibrates, depending on availability. So that is my take on it.
All right, thank you so much. And we have at least few new attendees. So I will be very appreciative if you guys can drop in a feedback to me. I believe all of you have my number or my email to reach out. And before we close, anybody has any other final comments about the case, about the discussion we had? We are 15 minutes out of our time schedule. Anyone has anything? Praneeth, you have a final closing comment on this?
Nothing more to add. It was a good discussion. Got a lot of learning points for me.
Okay, all right. Thank you all for joining, and have a good night. And please, if you do have any suggestion, any constructive criticism, I'll be more than happy to receive that. Thank you, and good night to all of you.
Yeah, right. Again, meet in